A very good morning to all of you. I'll be speaking on a comparative study of the dacryocysto-rhinostomy with mitomycin C versus dacryocysto-rhinostomy with intubation. Embryologically, the lacrimal drainage apparatus starts developing by the end of 5th week and completely canalizes by the end of the birth. Anatomically, when we see the lower end of the nasolacrimal duct, when it's obstructed, gives rise to epiphora. So, the gold standard method of this, gold standard surgery to deal with this is the conventional method of dacryocysto-rhinostomy. But there have been many various modifications with this conventional method. Although the failure rate of the with the conventional method is of DCR is 10 to 15% due to many reasons, being fibrosis, scarring, and granulation tissue at the site of osteotomy to be the most important factors. So to increase the success rate, there have been use of many adjunctive method in the recent past, like the use of silicone tubes and mitomycin C. So in our study we have seen the efficacy of these two procedures. The mitomycin C, being an alkylating agent, inhibits the synthesis of collagen and proliferation, helps reduce in the scarring and excessive fibrosis and adhesion at the operative site, which has been also shown by study by Semasari et al. And Shulau et al. Silicon tube intubation enhances the lacrimal pump function and increases the lacrimal tear drainage by increasing capillary action and helps in guiding the canicular epithelium to progress further. This has been seen as study done by Kim et al. So our chief objective was to compare the surgical outcome and efficacy of both these procedures and to compare the learning curve and compare the average time consumed in this procedure. The place of study was ophthalmology OPD of NRS Medical College and Hospital, Kolkata. It was a 1-year long study, observation, longitudinal and comparative type of study. The 100 patients were selected who were randomized into 2 groups with MMC in group A and intubation in group B, and they were followed up in 1st, 3rd and 6th month, and all the surgeries were done by a single surgeon. The inclusion criteria included all confirmed cases of primary nasolacrimal duct obstruction within 15 to 65 years of age group, and we excluded all cases of congenital, traumatic, infective, malignant and causes of nasolacrimal duct obstruction, any previous history of endonasal DCR, laser DCR or any pre-existing nasal pathology were also excluded. We used students t-test and chi-square test for comparing the 2 groups. Pre-operative preparations were done and conventional type of DCR surgery was done up to the making of the osteotomy and creating H-shaped flaps, and the smaller posterior flaps of both the lacrimal nasal mucosa were cut in all the cases. In case of group A, the mitomycin C was applied using cotton pledgets for 2 minutes and thorough washing was given. In case of intubation, 27 gauge silicone tube was used, 3 knots were applied at the end and the tubes were removed after 6 weeks interval. The post-operative outcome was seen after 6 months. The results shown that the chi-square test came out to be 0.955 with a p-value of 0.045%. This is the graph showing the gender distribution. Here we can see the females were more included in our study. The age-wise distribution in both the cases, 45 to 55 years of age group were more included. The success rate in case of DCR with MMC came out to be 92%, and that with silicone tube came out to be 96%. This is a graph, learning curve showing the number of complete procedures done by a single surgeon in months. Here we can see the operation with MMC could be done by the same surgeon within 2 months, whereas it took almost 6 months to learn the surgery involving silicone tube due to its technical difficulties. This is the average time taken to complete the procedure by the same person. Here we can see the total maximum number of surgeries involving MMC was completed within 30 to 40 minutes by the surgeon, whereas the same surgeon took around 60 minutes to complete the surgery with the use of silicone intubation. The causes of failure in our cases was with MMC 8% and with silicone intubation 4%. With MMC it can be due to profuse bleeding leading to washing of the MMC from the site of application, or technical difficulties, or traumatizing the nasal mucosa while applying the MMC. In case of silicone intubation, it may be due to granulation tissue formation at the site of knots or trauma during the procedure. So in case of conventional method, the successful outcome is almost 85 to 90%, but with the use of MMC or silicone tube, the success rate increased to 95 to 98%. These are few of the studies which we have compared with our study. To conclude, the surgical outcome and efficacy of both the techniques are at par with each other, but the learning curve of DCR surgery with silicone tube intubation is obviously prolonged and requiring more expertise, and also the average time taken to complete the silicone tube intubation surgery was more than with that of the MMC. The limitations are study-wise. It was a small sample size with restricted age group within 15 to 65, and a short follow-up period of 6 months was done, and obviously it was a single institutional study. Thank you.
At what stage did you apply the MMC? At what stop of the
after
DCR?
creating the osteotomy and making the H-shaped flaps, after that we applied the MMC.
Where exactly did you apply?
At the osteotomy site.
At the edges of the osteotomy site?
Yeah,
you
ma'am.
mean?
Yeah.
Okay. What was the concentration that you used each time?
We used
or was the
0.2
same?
mg per ml.
For how many minutes?
2 minutes, ma'am.
Each time?
Each, yeah.
Okay.
It was a single flap technique for you, or both the flaps you had?
Ma'am, sorry?
Single flap technique or both the flaps? Superior and inferior, nasal mucosal flaps?
Ma'am, both the flaps.
Both the flaps. Okay.
So what would you recommend? Based on your study, would you recommend surgery with MMC, without MMC, or
So,
with
ma'am,
intubation?
it obviously depends on the surgical expertise, because as I have shown in my study that the surgical expertise for doing a silicone tube intubation is much more than that of the MMC, where we only apply cotton pledgets. So if the surgical expertise is at par, we can use any of the method depending on the cost effectiveness, because silicone tube intubation obviously costs more.
Okay, so you would not recommend doing any DCR without MMC?
No, ma'am, obviously I would recommend, because the outcome is good with the MMC only rather than conventional methods.
Can you quote any study in which it has been done, a primary NLDO, in which a conventional DCR is done versus a DCR with
Ma'am, there have
MMC?
been many studies. I have mentioned in Canacillo et al. that the study was done using MMC in primary NLDO just to see the efficacy of the MMC.
Now, the complication rate is more with the intubation. Have you studied that?
Ma'am?
The
Yeah,
complication
ma'am, the
rate
complication rate is definitely, I have not
because
shown
of
the
the granulomas, infection, patient
ma'am,
loss
I
to
have
follow
not
up,
shown
not
the
coming back for
complication.
removal. So, in cases of primary NLTO, how frequently would you recommend doing DCR with intubation? All these were adult patients?
Ma'am, 15 to, on adult patients, ma'am.
No, that's what I'm asking. How frequently would you recommend doing DCR with intubation? In a primary, not in a failed DCR or pediatric DCR.
Ma'am, that too, it depends upon the surgical expertise after all.
What was the time frame in which you removed the silicone tubes?
Sir, in all the cases, we removed it within 6 weeks of enter. Thank you.